The broadcast is now starting. All attendees are in listen-only mode.
Hello again, everybody. This is Danny Bobrow, President of AIM Dental Marketing. Welcome to this installment of the Practice Perfection Web-Based Education Series. Today's very special presentation is entitled The Dental Team as Oral Environmentalists. And I am thrilled to be hosting my good friend and fellow founding member of AOSH, Shirley Gutkowski. Ms. Gutkowski is recipient of the prestigious World Congress of Minimally Invasive Dentistry Leadership Award, popular author, speaker, radio host at blogtalkradio.com, and career fusion coach. Her book series, The Purple Guide, continues to grow with Confronting Caries and paper persona available at rdhpurpleguide.com/books. Her vision takes attendees beyond the leading edge and, perhaps not surprisingly, has attracted no small amount of controversy. From A1C to joint vibration analysis, tech scan, and xylitol, Shirley is passionately determined to lead dentistry into the 21st century. I know we're there, but not all of us are. Today's event is being underwritten by Springstone Patient Finance, who have repeatedly demonstrated their support of practices committed to oral systemic health by supporting organizations with a demonstrated commitment to the cause of enhanced care. Now, before we get to today's event, let me remind you that Practice Perfection webcasts run for around 90 minutes. While attendees are in listen-only mode, we do invite you at any time to submit your questions or comments using the question button on your screen. We will do our best to allow time following the presentation to get all your questions answered. If we do not get to your questions during the webcast, we'll see that they're answered shortly thereafter. Now, attendance at this presentation entitles you to receive 2 hours of continuing education credit. Shortly following the webcast, you will be emailed a brief survey to complete. My team have asked me to say that because this is a manual process and we need time to format the recording before we can send you your email, we ask that you please be patient. If you do not receive the promised email by Monday, June 30th, you are most welcome to contact us, but please do not contact us prior to that. We are definitely diligently working on rendering the recording and getting your email to you. Once you do get the email, you'll have 30 days from that date to complete and return the survey to us, and you will then receive your CE certificate. And with that, it is my distinct pleasure to welcome my friend and someone who is truly committed to helping others in a way few can match, Ms. Shirley Gutkowski. Welcome, Shirley.
Well, thank you so much, Danny, for that awesome introduction. And I will have to say that you created that yourself. It's not one that I sent you, so it makes it even more impressive. So thanks for inviting me to talk about the Oral Environmentalist. And this is the reason why I am so passionate about this topic. I'm sure that anybody who's a clinician in this audience can spot the suicide tooth. And the suicide tooth is one that has had a cavity, has had a filling, had another cavity, had another filling, had another cavity, had another filling, had a crown, had a root canal through the crown, had a crown replaced, had another cavity under the crown, and now has another endodontic lesion, as we see right here. And what makes this so astonishing is the tooth right next to it pretty much has nothing wrong with it. So what happened? Why is it that this tooth did this, and what could we have done in the meantime beforehand, or just beforehand altogether? When we look at teeth, we very often see a situation like this, which looks perfectly fine and normal, and thank goodness for x-rays, we have the ability to kind of see through the tooth and figure out what exactly happened here. And I don't care where I've been across the globe, the answer to this kind of a problem is the patient needs to brush and floss better. And I don't know about you, but, well, maybe I do know about you. I think we all know that that just doesn't work for everybody. It works really well for dental hygienists. It works really well for dentists. It works really well for dental assistants, but it doesn't work really well for everybody in the world. So those are the kinds of things that we're going to be talking about today. I want to kind of talk about what is a good biofilm, what biofilm diseases can lead to oral disease, evaluate some of the early diagnostic tools, and create this idea of a risk factor manager in the office. I think all those things are really important. What we do in dentistry is we continuously get distracted by the hole in the tooth. And that's not fair to us, and it's not fair to patients. Every now and then we see a situation like this, am I right? And we go into this big whole long thing about angling the bristles and pushing this around and doing that and using floss, and how about wrapping the floss around a different finger and yada yada. How frustrated does a dentist have to be to practically put an amalgam on an anterior tooth? This could be a mess mouth, I'll give you that, but in general, most of us, most dentists, most dental hygienists are totally distracted by the hole, and that's really just not fair. We really have to think through what it is that's happening and realize that we don't act on what really causes cavities. If we took a tooth out and we dumped it in a bucket load of sugar, what would happen? Nothing. If we continue on with soft drinks the way that we do, nothing could happen. Poverty is often isolated as a cause for cavities. That is only partially true. If you have a patient who is living in poverty or who is very poor, they will have a higher incidence of decay, but it's not because they're poor. Just like the lack of insurance is not a cause of cavities, and neither is breast milk. It's a bacterial infection. When I talk to patients, I say, look, you have an infection in your teeth and we have to get rid of it. You have different kinds of infections in your mouth, and you have different ways of getting rid of it, and the caries causing germs are driven by pH. And when your mouth is in a proper pH, you're going to have cavities. And by all of those other things, you're kind of moving towards that really optimal pH for cavity-causing bacteria. We also know that cavity-causing bacteria are passed on in families. And I don't know that enough people really are acting on that idea. We have a window of infectivity that comes at the age of about 15 months, although we found cavity-causing bacteria in children as young as 3 months old, and that can be mitigated by using some of the science that we have available to us right now, by altering the environment of the person who's going to be passing on this cavity-causing bacteria to the child. We can manipulate the oral ecology, we can domesticate the bacteria, and we can do more for our patients than just another long lecture about angling the toothbrush bristles, using a power brush, using a different kind of floss, yada yada. Not everybody is capable of cleaning their teeth or removing the bacteria the way that a dental hygienist or dentist or dental assistant can. And that's just the truth. There are people who can do a heart surgery, there are people who can fly airplanes, there are people who can do a lot of other things, but they may not be very good at brushing teeth. And part of the reason is a biofilm. What happens for most patients is they are treated way over here in this maturation cycle of a biofilm. Okay, we kind of wait for the infection to spread. This, obviously, if we're talking about dental decay, we're not talking about inflammation, but the line is the same and the idea is the same. This is where we intervene. This is where we could be intervening, and this right here at the critical colonization is where we usually do a prophy. And we expect our patients to bust up these colonies at this stage. But really, there's so many places where they can't reach with a brush or with floss. No, not many people brush their palate. I don't think any hygienist is instructing their patients to brush their cheeks. You know, all of these different areas are achieving biofilm maturation status and then seeding other areas with these mature biofilm. So it's best if we can do something more over here, and we really can do more at the colonization stage. We also have to remember that there are yeasts involved, and that yeasts are really problematic. In early childhood decay and in decay in dependent people, people who are dependent on others to clean their teeth, usually we say reserve that term for elderly or people in a long-term care facility, but people that have accidents, we're able to keep people alive from infancy on that may not have the same quality of life as others. I don't know if there's a PC way to say that, but those people like that who have to depend on other people to clean their mouth, for instance, do have a higher incidence of yeast as part of their biofilm, and you can remove some of the bacteria, but if you're leaving the yeast behind, you're having another big problem still in the works. This is probably the most famous picture of a biofilm, and it kind of illustrates all the different parts of what I've been talking about here. A biofilm is an entity in and of itself. Each biofilm is its own entity, and it lives in its own manufactured environment. So even though you have a biofilm on a tooth, the buccal side of the tooth has an entirely different entity / biofilm than the lingual side of that same tooth. So we have to kind of think about that as we're managing the biofilm and when we're thinking our way through this whole system here. We have different environments in the mouth that lend themselves well to different environments with respect to these biofilms. We know that HPV, for instance, lives mainly back in the tonsils, and if it's going to switch over to a cancer, we'll find it at the base of the tongue. We have lactobacillus and E. coli and a whole bunch of other main groups living right here on the surface of the tongue. We have a different environment again on the enamel of the tooth, and then another one again on the root surface of the tooth. We have to also consider the surrounding areas. We have Staphylococcus, for instance, that will live right here on the epidermis. We have a different type of skin tissue right here on the lips, and it has no oil glands. I don't know why that's not more, why we don't think about that more, or why it isn't taught harder or as a bigger deal in school. I came across that information when I was putting together a presentation for a long-term care facility. They were talking about these people with their dry lips and all this stuff, and I was like, all right, well, whatever, dry lips comes from not enough water. Well, it also comes because there are no oil glands on the tissue. We have keratinized tissue inside the mouth, obviously. We have calcified tissues that lend themselves to other kind of biofilms and other kinds of diseases. We have the enamel that can decay and break down into horrible mass. We have epithelial tissue, we have collagen, we have a pocket that has its own environment over again. It's very complicated when you start breaking it down like that, but once we start talking about different ways of addressing these biofilms, I think you'll be surprised like I was. And I'd like to also remind you that it isn't all about the sugar. We cannot continuously tell our patients to avoid sugar. It's almost impossible. There is obvious sugar, as we see in this infographic here, and there's plenty of sugar in all of these drinks, but it's not just the sugar. It's partly the acid and partly the kind of bacteria that is living in the mouth and the host response. I'm not going to talk probably anything more about the host response, but we have to figure that in to the entire equation, especially when we're dealing with families where one child never brushes their teeth, and that kid never has a cavity, and don't you just want to just flick them in the head with, right here in the forehead with your middle finger. Don't you want to flick them? It's just not fair. So we have to really kind of back up and look at this thing from a higher level. I don't want you to leave here thinking that I said that sugar is okay. Sugar does cause problems. The World Health Organization has just reduced their recommendations for sugar, just in March of 2014. They had a recommendation of 10% of the calories, the daily calories, may come from regular old sugar, and apparently there was quite a hubbub when they did that a few years ago, and they held firm on that percent, but they came down halfway to 5% of the daily caloric intake allowable according to the World Health Organization. In 2003,
yes. Do you have a handle on, at least in this country, what the average percent of sugar intake is?
I do not. Do you?
I don't. I'm afraid to guess, but when you consider that we're talking about 12 teaspoons of sugar into 1 can of pop, I bet you it could be 30, 40, 50% for a lot of people.
It could be. And I'm not saying that sugar's good, and we can reduce the sugar, but when we only talk about the sugar with our patients with respect to decay, we're missing a lot of the boat, a lot.
We certainly are.
So let's take a second out here and have a poll question.
Speaking of questions, let's do that. We always like to get an idea of where people are at with respect to the topic at hand. So, Virginia, you want to go ahead and launch the first poll question? Okay, so other than sugar avoidance, which do you recommend for your patients? Which of the following dietary changes do you recommend for your patients? Would it be, and this is a multiple answer question, by the way, because you may recommend all of them for all we know. So take a few minutes and let us know. Is it xylitol, coffee, green tea, garlic, licorice root, and or? We have 41%, 50% voted, 55. Yep, we're approaching 100%. Come on, folks. We know you're out there. 80%. We'll just do it 5 more seconds. All right, very good. The results are that 100% of those in attendance recommend xylitol. 12% recommend coffee. 12% coffee, that's kind of, yeah, people don't realize that can actually, well, you'll talk more about that too. 47%, nearly half green tea, 12% garlic, 6% licorice root. All right.
We got ourselves a smart audience.
Oh, I knew that. Would I deliver anything less, Shirley? Not to you.
All right, so we have all of those are biofilm modifiers. This is the short list here that I've produced, and I think that we have plenty of opportunity to talk more about some of these other biofilm modifiers, and they work in kind of really slick, unique kind of ways. One of the things that that comes into play here is the generations, and then what kind of language that we can use within different generations. A lot of people know what antioxidants are. Lycopene has been in the news quite a while, and I think part of the reason why lycopene has such a high incidence of awareness is because of the word itself. Lycopene, I think, is a word that relates to people somehow or comes off your tongue easy, as opposed to phytonutrients, which is almost unheard of. Pretty much the word of the hour here today, because when you look at the antioxidant-rich foods, you will find that they are also very handy at eliminating the early colonizers in the biofilm. So I thought that was pretty cool when I figured that out. One of the things that is very high in nutrients and antioxidants and biofilm disruptability are berries. Berries have been underutilized, and they are coming into their own, and it sounds like this audience really has a good handle on that already. What I think you may not really get a good handle on is even, I'm considering cherries to be berries also, even though, you know, scientifically they're probably in a different class. But even things like cherries and cherry juice have been shown to be very effective at reducing inflammation. I was at a course, I think it was in Boston, it was over on that corner somewhere, last year, and one of the hygienists came up to me during the break, and she showed me this swelling in her wrist, and I thought, geez, that must hurt. She goes, this is less than half of what it was before I started using tart cherry juice. So she had been taking 2 ounces of tart cherry juice twice a day, and she had reduced the inflammation in that wrist at least. That was the obvious place the inflammation was reduced, to probably 10% or 20% of what it had been originally. The other thing about cherries is that it is also high in melatonin, and that people that were taking tart cherry juice were, at bedtime, were sleeping better. Now, I know a lot of people are cringing because tart cherry juice has a really low pH. Now, we have to remember and think back now when you were in dental hygiene school, what you learned about how the body reacts to pH that is ingested, different levels of pH that you ingest. When you take something in that's very tart, your saliva changes to be more buffering. It has a higher buffering capacity, and it obviously you produce a lot more, because even just thinking about tart cherry juice, I think, is making everybody's saliva kind of squirt a little, isn't it? So be very aware. And if your patient has really good saliva, don't worry about that. If they don't have good saliva, then you have a secondary worry, but it's easily maintained by using just some water afterward. Some of the other really cool benefits of the berries is that they have a COX-2 inhibitor kind of a feature to them. If you remember a while ago, it was a few years ago, that there was a, let's see, the COX-2 inhibitors, there we go, that's what I want, Vioxx was withdrawn because there was such crazy side effect of using a COX-2 inhibitor, and that side effect was a heart attack, and nobody wants to have that. So what we can do for our patients that are exhibiting periodontal infections and having some level of inflammation in the rest of their body, we can also help them understand that there are fruits and vegetables that will help reduce the inflammation within their entire body. Berries are very high in these COX-2 inhibitors. COX-2 is an enzyme that's produced in the body during a pain response. So if you can't reduce the pain, you can reduce some of these COX-2 enzymes that are being produced in the body, and by reducing those enzymes, you will also reduce a little bit of the pain. So how much of this do you need? Probably more than you care to have in a day. That's where the science is right now, is how much of these kind of ingredients are going to be helpful for you. And at this point, it's a very high amount, more than what you would normally want to have in your diet. So let's kind of switch gears here for just a second and talk about other kinds of functional foods. And this is kind of a weird term because a lot of people think that all foods are functional. And I'm not going to sit and argue or defend the term functional foods, but that is the term that we're using right now in all of the literature is functional foods. it's a definition that means that the food has another kind of a benefit over and above what you would normally think of as a food. Chewing gums are very cool. I really like talking about chewing gum because there is a lot of benefit to chewing gum. There was a video that someone posted to me, and I will send that link over to Danny afterwards, and he can send you that link along with the other information that he sends you. But it was a little artistic installation where identical twins were dressed to be identical, and then they were set up as they were in an exhibit. And the people who were visiting the exhibit then wore headset, and they were asked questions based on those twins, one of which was chewing gum. The twin who was chewing the gum had higher friendliness kind of points than the other one. The questions they were asking were things like, who would give you a raise if you asked for one? You know, two people dressed as a boss. And then the next question was, who would fire you for asking for a raise? And questions along those lines. And it was really astonishing. That little study showed that over 70% of the people who were chewing gum had a favorable response over their non-chewing twin. So not only do we have these benefits of putting things into the gum, we also have a social kind of a benefit to chewing gum. Now,
does that mean that everybody that's
know.
getting in trouble for chewing gum in school is really precocious, and the teachers need to be educated?
The teachers need to be educated on a lot of different things. We need hygienists in these schools.
That's right. And more gum.
More gum. We need more gum. So not only do we have, xylitol, we'll get to that in just a couple seconds here, but we have different things that we can put into gum that are going to be helpful for your dental health. We don't have fluoride gum in the United States, but I've seen it in Europe and I've seen it in Australia. So we have a way to deliver fluoride that isn't, I'm going to tread on kind of sacred ground here, not that big of a fan anymore of fluoridated water. I think people who need extra fluoride should have it, and if we can put it in gum, then maybe that's a better delivery vehicle for the people who need extra fluoride. Aspirin is not something that we talk about very often, but there is at least one aspirin gum, and it is very effective. Not only do you get the aspirin to be absorbed in the stomach when it gets that far, but we also get a little bit of the aspirin is absorbed through the mucosal tissue. Why use gum? Because it's easy to use. We have other ingredients in gum also. Magnolia bark is in, I want to say it's extra. Orbit White has bicarbonate in it, and we know that bicarbonate will increase the pH of the mouth to a place where the biofilms have a more difficult time surviving. Xylitol, erythritol is a new sugar to most of us. If you have ever looked at the ingredients list on a box or a bag of Trivia, you'll recognize erythritol. Green tea is put into some gums, and cranberry is going to be huge, huge. We also have these other ingredients that we could put in there, arginine, for instance. It really helps the basophilic bacteria proliferate. It produces an ammonia compound, so it counteracts the acid. It is a self-promoting kind of a product that is made in the liver, and you can find it also in the proarginine prophy paste that we've seen from Colgate. This was a study that was done just looking at different chewing gums and why we would want to use the chewing gums. So we have a higher acceptance of the different medication. People who can't drink water or shouldn't drink water have an easier time chewing gum to get their medication than not. There are local and mucosal actions of the medication potentially. We also know that we have this direct systemic transmucosal absorption, and so it starts working faster. And now we also know that you can build friends faster, right, using the chewing gum as based on that study I was just telling you about. It was done by I don't know, I hate to call it a study because it was an art installation, but those were the findings that they found there. This was another study that looked at participants who chewed equivalent gum pellets at both learning and at recall. And those study participants experienced significantly superior word recall compared to those who had different gum numbers at those different times. So if they had 3 pieces of gum while they learned the word and 3 pieces of gum when they tried to recall the word, they had a better recall when they had the same number of pellets at both times. So we have a couple of studies that look at recall and memory and stuff like that with chewing gum. But what's interesting about that in particular is that there's quite a controversy going on. When you start looking at PubMed and looking at chewing gum studies, yes, you can find chewing gum studies at PubMed. You will see that there's a little controversy brewing about memory enhancement with chewing gum, pros and cons. So be aware of that. When we're talking about biofilm management in particular, we have to talk about xylitol. This is one of the first things that I think we've been aware of in dentistry about using an adjunct to disrupt the oral biofilm and to force a healthier biofilm. And xylitol has proven over and over again to be very effective at accomplishing that goal. We know that xylitol is available pretty easily in all kinds of foods. We don't see that we have enough xylitol to make a difference, though. We do have enough xylitol in these foods to allow us to have a conversation with our patients to allay their fears that this is some kind of a man-made, lab-made kind of a sugar and that they should be worried about consequences and all this other stuff. There's really very few negative consequences with respect to xylitol. You wouldn't want to give it to somebody that has irritable bowel syndrome or something else because it does have the most widely known adverse effect of xylitol is that gurgling kind of stomach and that little GI effect. Some people are more sensitive to it than others. As we're learning more and more about the gut biome, we are understanding things like that a little bit better. But xylitol is still very effective and should be your first go-to product. Xylitol is effective in children. We know that. We have known it for a really long time. This is a study here from 1999 showing that long-term caries risk is down 93% in teeth erupting during the second year of use. And this habitual use in this study was, I think, 4 times a day. It wasn't excessive. What I've been running into lately is dentists who say there's a low compliance or that there's an issue with xylitol. The current recommendation is to use xylitol 5 times a day, and what we've found really is that if you strive for 5 and get to 3, you're still doing a great deal of help for your teeth, and you are also disrupting the biofilm. One thing that doesn't seem to come up very often in the studies about xylitol is xylitol use in elderly or in dependent adults, and that's not by accident. Most of what we know about decay in in the elderly or in people who have ended up in some kind of a long-term care facility is that they have a lot of lactobacillus in their biofilm, and that's what leads to root decay. And so when we talk about xylitol, we know that it has a really substantial effect against strep mutan. So when we're looking at dependent adults, we're like, well, is it really going to work? Well, it does, because of the way that xylitol works against the early colonizers. This was a study from 1995, and it showed that the people in a long-term care facility had a choice between xylitol or sorbitol, and then the third group was a control group. And the people who had the xylitol or sorbitol had up to 10 grams per day. And what they found is that there was no root surface decay in the xylitol group even after the study had ended. And the plaque scores in those residents was much lower and in the xylitol group than in the other two groups. So that just goes to show how the xylitol works against those early colonizers. It makes it harder for those early colonizers to colonize. And it makes it so that the biofilm can't mature. And if you don't have a mature biofilm, you don't have as many inhabitants in that biofilm. This was a study looking at how much do we need to have in order to make a difference. And this study showed that there was 10 times lower strep levels than at baseline, just using 7 to 10 grams per day after just a few weeks. So you'll see results after a few weeks. So don't discount it. People don't floss either, but that does not stop us from recommending flossing. Don't not recommend xylitol because of a compliance issue. And when you're recommending xylitol because one kid in the house has a cavity or 3, then you need to recommend it for the entire family. If there are 5 people in the family, then all 5 people need to be using xylitol because they're going to be distributing that bacteria back and forth, and that infection is never going to go away. So if we treat it as if it's an infection and that we can manipulate the biofilm and, you know, operate more like an environmentalist, then you're going to have better results, and you're going to have an entirely new conversation with your patients. And that's one of the other goals here. We need to have new conversations with our patients. I did an entire course with a friend of mine, Patty DeGangi, and we called it Killing the Parrot. Because patients don't even hear us anymore. All they hear is brush and floss, brush and floss, brush and floss. And it's time for that to go. We have other options here, and that's what we're talking about here today.
Right. Yep, I was at that talk. It was great. And well, you need to say brush and floss more. I like that.
Brush and floss. Well, you know, that brushing and flossing is never going to go away. That is a mechanical means of reducing the biofilm. Washing is not bad, but we can't just hang everything on it. It's just not working for enough people. Xylitol is also effective against yeast. It doesn't allow the yeast to hang on, and it doesn't get trapped up into that biofilm as easy. And I did a little study at a nursing home well, Angie and I did it together. We did it alone together. And this is what we saw after 3 months of using xylitol a few times a day. We had an 80% compliance rate, sorry, with the CNAs. I don't know of another study that had an 80% compliance rate with any intervention with respect to oral care. It's crazy. It's crazy that we're expecting these CNAs to provide the level of oral care with 30 minutes of education than a dental hygienist can provide after 3,000 hours of education. A CNA is never going to think about xylitol. A dental hygienist is going to think about xylitol first and other options, not just xylitol. But really what happens when dental hygienists go into these care facilities is the first thing they do is try to teach brushing and flossing. This is the reduction that we saw after 3 months. You can see it's still not perfect, but you can see here the amount and just the density of the biofilm on the teeth at the beginning and how lightly colored it turned out to be later. So we really did make a big impact here, and the patients were grateful. Nobody doesn't like candy. When you're talking about your own patients, though, it would be worthwhile to also instruct them in using xylitol as a nasal spray. That bacteria also lives in the sinuses. Erythritol
let me
is...
just share, since you mentioned that,
Sure.
let me share. I've been using it as a nasal spray for almost a year. I had chronic sinus infections, and I have not had one episode since I've started using this stuff. So maybe not a robust statistical sample, but it works for me, and I recommend it to all my friends that have that issue.
I hear that everywhere I go, Danny, everywhere I go. Hygienists stop me and say, I used to have sinus infection so bad it would turn into bronchitis, and every 3 years I'd have a bout of pneumonia, and it's eliminated that. So not only will it, yes, it
one blast
affects
in the morning,
biofilm.
each nostril, one blast at night, and you know, as part of my routine, I've got it right on the bedside, and you know, you get used to that little sweet drip, and then it's over, and yeah.
And you go on with your day.
That's right.
Because you can feel it penetrating the biofilm as it's entering into the sinuses, and that's what you feel going back down your throat. That's what that
Right.
sweetness is.
Yep.
So,
and I have a very positive association with it now because I know I'm cleaning out
Right.
cleaning out the attic, you know. Yeah. All right. Sorry. Proceed.
So when we're talking about polyols, and that's what xylitol is and that's what erythritol is, we have to kind of look at it in two different ways. We have polyols that are good for teeth, like xylitol, and we have polyols that are not bad for teeth. And most of the other polyols fit into that. Right now, erythritol is still in the not bad for teeth category, and xylitol is in the good for teeth category because it does not only does it break down the biofilm and adjust the biofilm to be more healthful, it also has an affinity for calcium, and it brings calcium into the teeth. So there's a whole nother mechanism of action there that has yet to be explored. So xylitol is good for teeth, and erythritol right now is in the not bad for teeth category. It is another bulk sweetener, just like xylitol is. It has a high digestive tolerance. It's safe for people with diabetes as well. It does not promote tooth decay, hence the not bad for teeth category that I put it in. There are some scientific studies to show the benefits of erythritol, and one of the more interesting ones to me is this study right here, the effects of erythritol on endothelial function in patients with type 2 diabetes. So what they showed in this study was that the erythritol ingestion, so it's not like you smear your erythritol all over your veins, haha, that doesn't happen. But by just ingesting it and having it be part of the diet and to, you know, increase the amount of it, they found that patients with diabetes were healthier and had better vascular system by using it. There are early studies to show that erythritol does help reduce the plaque on the teeth as compared to xylitol and sorbitol. And so these are the earliest studies. We're waiting for more. So we will see. We have to keep our eyes open and keep our minds open. And even though it may hurt to say that erythritol might be a little better than xylitol for dental purposes, we're not all the way there yet. Products that contain erythritol, Mentos gum flavors. You really have to look at all of these ingredients, especially with gum. The gums change their ingredients all the time. And when you tell somebody that XYZ gum has whatever in it that you want them to have, you have to let them know to check the ingredients list first, especially with the over-the-counter one. Especially the, I don't know, the big brands, I guess, is a better term to use. Gums like the Spry brands and some of the other xylitol gums that you'll get at a health food store will always have 100% xylitol in them. But when you talk about Starbucks after coffee gum, 2 flavors have xylitol listed as the only sugar today. So, so you don't want to send your patients on their way for after coffee gum at Starbucks and tell them to get the peppermint flavor, and then today's the day they whittled it down, and now xylitol is only just, you know, a magic word that they whispered over the pot when they made the gum. We also have probiotics.
Even if they mention it, it doesn't mean that it's the primary ingredient. You know, it just might be in the list, but it won't be #1 necessarily in the list.
Right. That's why you have to check the ingredients list over and over again, because they switch it around. Sometimes the xylitol may be the first sugar, it may be the only sugar, and then you come back in 2 months and now all of a sudden sorbitol is the #1 sugar. So it's best to just stick with the health food store brands. I'm a big fan and big promoter of Spry, so that'd be my choice. You know it's going to be fresh. You know it's not going to be sitting there on the shelves forever. So that's where I'm at with the xylitol. So probiotics, though, are up and coming. We hear about probiotics quite a bit with respect to gut health, but we also have probiotics that are very effective at adjusting the oral flora. The best way to use oral probiotics is to provide the patient with prophylaxis first, and then start incorporating these probiotic strains into their mouth. So you would clean their teeth, polish them up, and then give them a probiotic to use, and then they would use that then for the next few months or forever. Just like xylitol, there's no reason to stop. There's plenty of reasons to start, but there's really no end point. There's no do it for this amount of time and then you're done forever. There's just no real reason to stop at all. There are 2 companies that have probiotics right now. One is called Evora, and Sunstar product is called Perio Balance. So you can look for those. You can see ads for those in all the magazines, too. So let's talk a little bit more about food as medicine. And one of the things that I'm going to show you next is not something you're going to expect. So if you are a vegetarian or a vegan, then maybe you will want to close your eyes for the next 2 slides. Because, ta-ta-da-da, rabbit has been deemed a functional food. They have manipulated the diet to be very effective in increasing essential levels of these parts, the FA and the EPA, and I don't even know all what they're all referring to, these essential acids, these essentials in the meat. They grow rabbits very much like they grow chickens, and it is considered to be a very sustainable meat choice. So even though this article says that rabbit is quickly becoming a favorite for conscientious home cooks, I have yet talked to anybody that has ever cooked a rabbit that wasn't hatched on a farm somewhere. So, but look for that. When you go to health food stores, look in the freezer container and see if they do have rabbit in there. It really doesn't look like a rabbit at all once it's in the freezer. I'm sorry, that's all the meat talk that we're going to have today.
All right, everyone can get off.
Yeah.
So it looks and tastes like chicken, is what you're saying.
That's right. So dental functional foods that adjust the biofilm and the oral flora include cranberry and licorice root. Even cocoa and coffee have been studied to really show what these functional foods can do for the biofilm. And when you're talking about plants, the word that comes up often is flavonoid. Now, there's a whole list of new words and new ways to use these words in functional. And it's hard enough to understand all of these and work with all of these, but they switch up the terms mid-sentence a lot of times when you're reading the studies, and the terms are nested in a way that makes it even harder to understand. So I'm just going to give you a tip that I'm just kind of learning to live with myself, is that it's the flavonoids that you're going to want to look for. So that's the overriding term. When you're looking at cranberries, the word proanthocyanidins is going to come up often. And what the proanthocyanidins do, which is a flavonoid, is it makes it more difficult for the bacteria to adhere. I finally landed a scientist to talk to about this, and we kind of compared notes with respect to biofilm formation in the urinary tract as compared to the mouth. So in the mouth, we have Streptococcus mutans, and the strep mutans create that mucopolysaccharide covering, and then that protects the entire biofilm, and then those strep mutans then invite others in to that biofilm. And in the urinary tract, you have the E. coli, and that attaches originally using like little fibers that come off of the bacteria and lodge into the soft tissue. So there's a different attachment mechanism, but these proanthocyanidins in the cranberry seem to work on both. Proanthocyanidins belong to a larger category of plant chemicals called flavonoids, see? And then not only are there proanthocyanidins, there are also proanthocyanins. So it just gets to be extremely confusing. This is another little confusing bit here. Sometimes you'll see the term OPCs, which is an abbreviation for a different kind of a proanthocyanidins. And this is just to show you how confusing all of that can be. And if you just kind of remember back that these are all flavonoids, then I think you're going to, all of these studies are going to be easier to understand. A variety of plants contain these, including teas and berries and seeds, and they are useful antioxidants, and they're found a lot in the red wines. So with respect to biofilm management, we have cranberry juice, highlighting the list once again, and even when we're talking about perioral biofilm. So that's another thing about the cranberry research that you're going to find is that you're going to see the term high molecular weight cranberry. And when I was speaking to that scientist, I made him tell me what the heck that was because I couldn't figure it out for myself. And it's so simple, you're just going to laugh. What they do when they create these different cranberry substances is they push them through different screens, and then the screen sizes get smaller and smaller, and then the smallest parts are called low molecular weight, and the bigger parts are called high molecular weight. So if you can get the benefits that you want from high molecular weight cranberry, then you miss a few steps as you have to make it be smaller, you see. So what they're trying to do is find the biggest particle that they can use to get the effect that they want. So that's where part of the science is going. But you're going to start to see all of these kind of cranberries products coming into dental. And you can rest assured that it's going to be helpful for you. Another really cool thing that they're doing is they're using different plant parts. The bark of plants seems to be coming up often in biofilm management, and they are using bark from plants that you would never even imagine. So these scientists just figured this out on their own, and this particular plant here, the ulmus, we'll just call it the ulmus anyway. Some of these plant names are just crazy. I wish I would have spent more time in my botany classes, but we're finding that they inhibit osteoclasts formation. And so what that may be able to do in dental products is to reduce bone loss in our perio patients. So we have not only the ability maybe to reduce the biofilm, but also to stimulate health or at least stop breakdown. How many hygienists do you know read biofouling magazine? Probably less than 10, right? So this is where this is where some of the science is coming from. Go ahead, Danny.
I just was saying, if they did, they haven't admitted it to me. It's quite a name. They could use an image consultant, I think.
That's right. So what they studied here is the effect of these polyphenols against strep mutans, and and they found it to be pretty effective. So you know, they're using this kind of science all over the place, not just in our dental literature and in our dental discussions. Carotenoids include beta-carotene and lutein and lycopene, and those are also found in highly colored vegetables. And we are finding that carotene-containing biofilms are disruptive to certain bacteria. In this study, they were looking at the Pseudomonas biofilm and found that the yeast had a real hard time living in there when there was enough of the keratin in that biofilm. This is the Journal of Clinical Periodontology, so maybe it's a little bit more comfortable home ground for the people in this audience. And they found that keratin in patients with periodontitis who were 60 to 70-year-old men was low. They had low serum carotenoids in those patients with periodontitis. So that may be something you want to include in your recommendations for your patients who are over 60 and have periodontitis. Now, this study was only men, but, you know, keratin isn't exactly a highly caustic medication, so I think you'd be safe in recommending it for just about anybody that has a periodontal condition. Prunes. Oh yeah, prunes. If you remember back on the pictures I was showing you with different foods and the amount of xylitol in those foods, you'll remember that prunes was in my list of the highest amount of xylitol in there. It's unclear as to whether or not the xylitol in the prunes is what's causing the benefit, but prunes have been studied in a total of in studies that looked at 15 different oral pathogens, including our famous Streptococcus mutans. And so what do they do with prunes? Well, they used a prune extract and they put it into a suspension. And so we call that juice in layman's terms. And it did inhibit all of those bacterial species. Okay, so let me go back one screen here and show you that strep mutans was included in there, Sabrinus and mitis and sanguinus was also included in there, lactobacillus was in there, P. gingivalis. So there were quite a number of pathogens that were studied with this suspension, and they found that it was inhibiting all of them. Prunes are pretty easy to get anymore. Sunsweet prunes, some kind of sunny prunes, are individually packaged, so you could eat them easily in the car, or you can just swish it as a juice, as they did in this suspension. This was again in another issue of Biofouling magazine, and they found a considerable reduction in biofilm formation. So really what you're asking your patients to do is to look for highly colored vegetables and fruit and not to alter them heavily, and try to maintain that kind of a diet. Now, we can talk about supplements, I suppose, but supplements in the United States are a little bit iffy, and we have to kind of remember that it's unregulated, and unless you really know the company well, You just don't know what's going to be in those capsules, and the best you can do is to stick with the actual food itself. If you need higher levels of carotene or some of these other flavonoids that we've been talking about, you can try different levels of them, and you can see how they work in your practice. I also like to talk about keeping tabs of these kinds of things in your practice, and even write them up for different articles. Cocoa, yay, cocoa, was studied in 2009. In this study, the preventive effects of cocoa-enriched diet on gingival oxidative stress in experimental periodontitis, and it showed that it was very effective in reducing the oxidative stress because of this high antioxidant property that cocoa has. Now this next picture is not cocoa, it is coffee, and that is the actual cup my friend was given. She asked for a large cup of coffee. That's what she got at this one coffee shop where we were visiting. So cocoa and coffee both were studied on their effects of caries, gingivitis, periodontal disease, all of these different oral conditions. And the data suggests that there is the lack of a strong evidence in particular regarding randomized clinical trials, which doesn't mean that you just toss it all. It just means that you can't hang your whole hat on any of this kind of thing right now. What we do have, though, is a good starting point. It's a good starting point to continue to look at and continue to study and continue to try to see what's going to work for your patient. Not every single patient has a desire to use more and more fluoride. I think everybody in this audience who sees patients is coming up against patients who are having problems with the normal things that we want to recommend for them, like chlorhexidine and fluoride, and they even question things like xylitol. So it's nice to have a variety of things to talk about to them. Cocoa polyphenol parameters significantly reduce biofilm formation and acid production by strep butans and strep sanguinis. So what does that mean? Didn't somebody come out with a chocolate toothpaste once, or a cocoa toothpaste? Wasn't so far-fetched. You know, this study here is from 2009. A lot of this stuff isn't brand new kind of stuff, so we really have to think about how we're using this science and how long are we going to wait for things to show up to be different or better. In this study, also in 2009, coffee can help prevention of dental caries if consumed without additives. The dean of the dental school at Loma Linda did a study with his dental students, and they found the exact same thing, that the students' pH, oral pH, increased when they drank straight black coffee. And when they started to include other things into the coffee, like sugar and cream, the pH would drop along with the acidity of the drink. And if you remember back in your books from school, that I don't know, was pretty evident to me that that is not a new phenomenon. If you're drinking lemon juice, your saliva is going to be more it's going to be more basic. It's going to have a higher capacity for buffering that acid. And it's the same with the coffee. If you're not checking your patient's saliva, you're missing part of the boat, because you don't know then what you can recommend. If they have a very dry mouth, you're going to have a hard time if they start using this tart cherry juice, for instance.
And Shirley, let's remind people they can always use xylitol as a sweetener in their coffee. That's what I do.
Yep. Xylitol is perfectly safe.
I do sneak a little almond milk in there, too. So I guess 2 out of 3 is not bad, though.
Almond milk. Oh, I'm going to have to really go to YouTube and see how they make these nut milks. So here's, again, regular and frequent.
How do they milk a nut? I don't know.
Yeah, I don't know how you milk a nut either. Somebody told me that they soak the nuts, they grind them and soak them, and then they put them through screens. I don't know. It sounds like a big job.
And then they feed them to a cow.
Yeah. PACs are proanthocyanidins, may be a compelling candidate for testing in both animal and human models with respect to proliferation, inhibition, and apoptosis. Apoptosis, for those of us who don't remember what apoptosis is, that is cell death. It's a word that I don't remember learning ever, so I had to look it up. And a lot of these studies are from 2007, and this is the phone we used, in 2007. Does that mean we were dumb because we used this kind of a phone? Are you still using this phone? Probably not, because why would you when you have a smartphone now? Does that mean that we were wrong when we used that phone? No. And I bring this to your attention because things change, and we promote and we grow, and we need to have room for progress. And just because we did it that way before doesn't mean we have to continue to do it that way. There is room in our discussions with our patients for this kind of science. Grapes are bad news in most dental hygienicides, but it hasn't proven to be so in the studies. This was a study that looked at Raisin Bran cereal, or more accurately, a bran cereal with raisins and a bran cereal without raisins, and they added milk to include the way that most people eat their food, especially their Raisin Bran. And what they found is that the people who ate the Raisin Bran did not have the pH drop than the people who ate the bran flakes without the raisin. So over a 30-minute period, they found that the pH never really went below 6. So we have to wonder what is going on here. It's the same exact flakes. It's the same everything else except for those raisins. And when you really look at the composition of raisins, I think this may be where we get into a little bit of trouble here, because we think of raisins as being almost pure sugar. And if we're of the mind where we can only use sugar, or that we can only talk about getting rid of sugar, then we're really missing the boat. People are attracted to sugar from birth. It is not a learned taste. It is a survival. It's a survival of the sugariest. Things that were sweet to eat from caveman days were safe to eat. So we were programmed to eat sweet things in order to eat foods that we knew were safe. And so by avoiding sugar, or just telling our patients to avoid sugar, is overly simplistic. And we can't do that. We can't do that to our patients. It's just not fair. We have to give them something sweet to eat. This is a study on grapeseed extract that showed it is also very high in these proanthocyanidins, and it positively affected the vitro demineralization and remineralization process in artificial root caries lesions. And they were suggesting in that study that it may be a very promising natural agent for non-invasive root caries. So when we're talking about our patients in long-term care, we have to think to ourselves, instead of a fluoride varnish, maybe we should be putting a grapeseed extract varnish on the roots of these people's teeth. It's high, high, high in these proanthocyanidins. And when we're talking about licorice, we have to remember that we're not talking about, Twizzlers. We're talking about licorice root extract. And this is another term that I've already spent the year trying to learn how to pronounce, and I'm just going to leave it there for you to read, because it's a tricky word. But it is very effective in reducing the amount of strep mutans. If you remember a few years ago, there was a big hoopla about licorice root extract suckers, and they did even a report on the news about it, and they found that it was very effective, and the recommendation was to use that sucker for 10 days in a row every quarter. And I'm, again, thinking about people in long-term care, how they can get those suckers. wouldn't that be a good treat for them to have during the afternoon or in the evening? Do you think it would be hard for a CNA to use a licorice root sucker as an oral health aid in those long-term care facilities? How about kindergartners and first graders? Would they shy away from a sucker every 10 days, every quarter while they're going to school? There are better options. There are really better options than just hammering on the brush and floss message. Licorice root can be found in root beers and in teas. If you didn't want to get your patients sucked into the suckers, inhibited licorice root extract exhibits potent anti-inflammatory properties as well. So we're doing a lot of good when we're talking to our patients about licorice root. There is a caveat to licorice root. There is some science to show that there is an increase in blood pressure. However, that the amount of licorice consumption that you would have to have in order to get that increased blood pressure would be regarded as a bad diet and could not be sustained for health. So if you're asking your patients who are not on high blood pressure medications to steep some licorice root tea and use it maybe as a mouthwash or even to rinse and drink it, I think you would be perfectly safe in doing that. And let's not forget the tongue. There's a huge biofilm that lives on the tongue. We were not taught tongue cleaning. It was mentioned in 1986 when I graduated. But today, that's part of the sequence of new graduates, I think, from dental hygiene schools to clean the tongue. Tongue cleaning is imperative in long-term care as well, and you know darn well there's no CNA that's going to take care of a resident's tongue. We do know that tongue coating in long-term care is a pneumonia risk. So whatever we can do and learn about before your patient gets into a care facility, the better. If you're really good at recommending this or that tea for this or that condition with respect to oral biofilm, you're going to be way ahead of the game. Other tongue cleaning products include raspberry and plantain, nettle, and dandelion. I don't think that meant rubbing a dandelion head right on the person's tongue. I don't think that would be good. I don't know that you would want to squeeze cabbage juice into distilled water and clean somebody's tongue, but you could if they were that interested, and that would help cut through that biofilm and reduce the adhesion as well. So we're doing a lot with a lot of different things. On the horizon, we have things like ozone. Ozone is a gas. It's produced by electrifying oxygen. You hear about ozone quite often with respect to air quality alerts, and that is because air is not oxygen. Air has oxygen in it, but air also has a long list of impurities. And once you electrify those, you start to have other problems. So that's where this ozone thing comes from. It's these ozone alerts come from. You have to remember that this is air that we're talking about. And when we're talking about dental ozone, we're talking about pure oxygen. Very few dental practices. Yes?
Sorry to interrupt. Just want to, well, remind or advise maybe those who don't know, but we have in the past on Practice Perfection hosted two individuals that know quite a bit about ozone. One of them is really the father of ozone in dentistry, Dr. Julian Holmes, who joined us from South Africa.
Oh, awesome.
And Bill Dome, who we both know, gave us a really compelling presentation. And both of these are available as archives. So anybody that's interested in learning more about ozone, let me know, and I'll be glad to send you a link.
Awesome. This was really funny. When I was putting a presentation together about ozone, I came across how to use ozonated water on ehow.com. So it's getting to be more and more mainstream, ozone is. But in dentistry, there's still a little hiccup there, but it is very safe to use. It is very effective at reducing bacteria, as you can see here on this oral DNA test. look at the red complex and the orange complex bacteria before and after an application of ozone gas. So that's how my family is being treated. I go to great lengths to make sure that my family has ozone treatment if they have dental decay. The body tolerates ozone very, very well. In study after study, we've been using ozone in the world since the 1800s to clean water, and that's been very effective in eliminating the pathogens that live in community water supplies. If you live in the Chicago area or the Milwaukee area, you may know or remember back in the 80s this Cryptosporidium outbreak that we had in Milwaukee. It made a lot of people sick, really a lot of people, and some people died because of that contaminated water supply. And what they did in Milwaukee is they built a huge ozone facility that now ozonates all of Milwaukee's municipal water supply before it reaches the sink. So that's really good. And this is ozone gas being used to whiten teeth at a dental practice. You can't even see, let's see if I, she's using just a tiny cannula right here with the ozone hose from the generator. I think the generator is back behind her. And she's just ozonating that, those teeth. And this big, you know, elephant snout here is the evacuation suction that they use when they're doing amalgam removals. So it's pretty safe to use. They just have a slight vacuum happening right there, and the practitioners are healthy and happy. So there you go, for the most part, with respect to biofilm reduction and biofilm, and healthy functional foods for our patients. We have plenty of those. So in closing, I'd like to just kind of summarize some of the things that I said today about shifting our thinking, that brushing and flossing and other mechanical plaque removal aids are okay. They're okay for biofilm removal, but we really have to switch our thinking to biofilm reduction. And once you start thinking about reducing the biofilm as opposed to removing it and brushing and flossing it away and bending the floss around the tooth, yada, yada, you are going to start to see other options available to you. We talked about functional foods with respect to medicinal sugars like xylitol, where that can reestablish a pH that is more healthful and allow the body to maintain its own health, because that's part of this equation as well. We have tools for early diagnosis that include things like fluorescence. When you take a certain wavelength and shine it down on a biofilm and it comes back as a red color, you know that you've got a caustic biofilm. If it comes back as a green, then you know that you have a biofilm that's safe and doesn't need to be managed. But unless you're using some of these extraneous tools, these outside of the tooth kind of tools, as opposed to a bent wire with a with a point on it, you're not using the diagnostics to the best benefit. We have to use these advanced diagnostic tools in order to maintain our patient's health. And if we're still relying on these bent wires, we're not doing them any favors at all. And we are causing them great harm, actually. And it's very close to, I'm going to say it, very close to malpractice right now. There are a lot of cases that are coming up and have come up that looked at using a probe or an explorer to detect decay or periodontal infections, and the practitioners are being questioned pretty heavily as to why they aren't using more advanced technology to detect decay and periodontal disease. I'd like to remind you that caries is not a fluoride deficiency, it is a bacterial infection, and that we have to manage the bacterial infection and not treat it as if the tooth just doesn't have enough fluoride, or that the tooth just doesn't have enough chlorhexidine. Those are two key things that I think will really help people, help the people in this audience really get a better handle on some of these other options and open their mind to other options. Don't forget the body's ability to defend itself. Once you support the body in its defense, you're going to have a healthier patient, you're going to have a healthier mouth. That carotene study with the periodontal patients that were 60 and over, that's a pretty good indicator that this is a very whole body kind of a disease. And this oral systemic link doesn't just stop at periodontal disease scraping. You know, we have other responsibilities to our patients even though they may not know it, not yet. And don't forget the nature of a biofilm. We can manipulate a biofilm. And we can use the environmentalist kind of a mentality to manipulate the biofilm to be more helpful, to domesticate the bacteria, if you will. I'd like to read this to you because I think it's profound. This is from a book called Operative Dentistry for Children. And I like to include it in all of my caries courses because it's profound. Let me tell you, it's profound. Not filling teeth, but preserving the necessity for filling teeth should be the dentist's work. Let him consider himself successful who can show a clientele where his patients boast that never from babyhood to the grave have they had a stain or hole in any tooth. That is true dentistry, not this tiresome, painful plugging of holes. It is an ideal possible for the majority of people. Why is our profession permitting 60% to suffer needlessly? And that was written in Chapter 3 of Dr. Evangeline Jordan's book, Operative Dentistry for Children, a little while ago. This is crazy that it's still the same today, that patients are still leaving the practice not knowing about xylitol, they're not knowing about the benefits of coffee for dental health. Who knew? The benefits of flavonoids and Proanthocyanidins and all of these other plant products, and the benefits of these dietary modified rabbits, all that kind of stuff. We have to stop this downward spiral. We absolutely have to stop this downward spiral. These suicide teeth are crazy. Everyone that sees a tooth like this should get a pain in their stomach. We have to think of the idea of good for teeth versus not bad for teeth. We have to also think about food versus something to eat. There's a lot of real estate in our grocery stores just isolated and saved for something to eat. And there's very little in our grocery stores that's really called food. And if we stick with the food, our patients are going to be healthier, and it's going to give them an opportunity to be healthier in general. So we have another poll question coming up right now. I'm going to wake Danny up because he's got to be ready with his little clicker finger to bring up the question.
I'm sorry, did you say something? Oh, yes, of course. Yes. Of course I'm paying attention here. Our next poll question is, how do you fit functional food discussions into your time with a patient? And this is one answer only. I don't have time at all. I don't have flexible scheduling, so cannot do it. I can do it while I scale. I don't know enough to have this discussion with my patients. I'd like to have the discussion and let others do the treatment. So just take a few moments to answer that. And we're about half the attendees have voted.
I'm very interested to see how this poll ends up because a lot of people have a lot of trouble getting enough time to do a lot of different things.
I think you're going to be pleasantly surprised in that case, Shirley.
Awesome.
And I would like to be able to share this. I think I will be able to in a moment. But the answers come in at the two first options. I just don't have time. I don't have flexible scheduling came in equal at 0.
Yes.
And we got 10% saying I don't know enough to have the discussion, 14% I'd like to have the discussion, let others do the treatment, and a whopping 76% said I can do it while I scale.
So most people do the double duty where they scale and they talk at the same time. And that kind of brings me to the idea of a risk factor manager. I've been promoting this idea since the first time I was at one of the Canberra meetings back in, I don't know, 2001, when Dr. Jensen mentioned it. And that was the idea to have a risk factor manager in the office and have one person in charge of all of the risk factor management. So that person would do the periodontal testing. They would do the saliva testing. They would do the cancer screening. And all of the actual prophylaxis, the actual treatment of any of the diseases that came up or any of the conditions that showed up, that would be a separate person. Because this is a highly desirable position for clinicians, and it's really desirable as well for our patients if they know that there is something like that available. I would like to submit that a person that is the risk factor manager in the office be a rotating risk factor manager, because I think it would be so much fun for so many hygienists that they would want to take turns. So maybe you would do it every week, you would switch off, or every month. But the risk factor manager would be in charge of things like new product research and data gathering. They would be developing treatment protocols, all the things that people who see patients all day, every day just don't have the time to do. The attributes of a risk factor manager look very familiar, I'm sure, to most of our audience members. This is not for somebody that resents going to work every day. You want somebody that's excited about coming to work every day, that loves progress and loves improvement and isn't hindered by that kind of thing. And so that would be the risk factor manager position in the office. And I think that would really help take some of the pressure off and get the job done. Get the job done for our patients. They expect this kind of treatment. This is called excellent treatment, and I think they really do expect that you're doing all of these things because they don't know that it's available to do and that it's not getting done. So let's go to the next poll question and see what that has to say.
Let's do it. Okay, our next poll question. Do you have time to develop, oh, there it is. Do you have time to develop new protocols at your office? Yes, no, or they're set by the doctor, so hygienists needn't worry about it. And we are almost 2/3 done with the voting. Come on, gang. We are sort of stuck at 2/3. I'm wondering if there's
That's all right.
No, there we go. Yeah, I know. It's all right. It's just sometimes I wonder if it's technology that's having a hiccup.
Right.
So we'll just give it a few more seconds. We are at almost 100% now, 80%. The suspense is killing me. How about you? All right, and the results, there you go, are 30% answered no to the question if they have time to develop them. 60% said yes, and 10% said that they are set by the doctor.
Well, that's pretty good. I'm still surprised that we had an audience that has that much flexibility in their schedule to allow them the time to develop different protocols as science demands. So congratulations to everybody in the audience, and I think that's really very cool. So if you'd like to continue to follow discussions like this, you can follow me on Crosslink Radio. I have an everyday radio program that delves into topics like this, and we have a lot of lively guests. I think we had you on already, Danny. And we talk about different aspects of clinical dental hygiene and dentistry, and talk about health through the filter of the dental hygienist. And I'd like to also invite you to take a look at Career Fusion. If you are satisfied with your position and just want to be recharged, or if you just want to change and see what else is out there for you. In July next month, we are going to be offering a presenters camp here in Madison, Wisconsin, so that is going to be pretty fun. We'll have 3 days of how to build slides and how to do presentations, including webinars, and where to stand and how to do the projector and how to build a slide and all that kind of stuff. And I'll also be speaking at Under One Roof this year in Chicago, and that's going to be August 14th to 16th. I'll be speaking on the topic of So You Want to Write. So that's what I'll be doing there. Thank you so much for attending today, and I'll be happy to stick around for some questions. And that's the next thing.
Thank you very much, Shirley. And I think RDH Under One Roof did made a wise choice inviting you to speak about writing. I think it's pretty clear to everyone that you are certainly a dynamic speaker. You write just as well, and I don't know how you manage to pull off a daily radio show while you do the work as a hygienist and Career Fusion and golly knows what else. But let's get to some questions. We have a lot of them, and let's just dive in because we don't have a lot of time, and I want to let people know some important housekeeping information, too, before they sign up. Does erythritol have the same digestive effect as xylitol?
It appears so. It may be a little milder, but because you need to, xylitol is almost exactly the same sweetness as sugar, so you measure it about the same. Erythritol, you need a little bit more. So because of that, it may be identical.
Okay. What do you know about hydroxyapatite? I understand there's a line of toothpaste available both in professional strength as well as over-the-counter.
Yeah, that's pretty cool. What we've found is that remember how I talked about the biofouling magazine?
Yes.
The majority of the studies on hydroxyapatite are in the engineering publications. So what happened is that the science kind of split off into that direction and never really made it back into the scientific literature for dental because it was proven back in the 50s to work. So that kind of information had been lost, and now it is found again. So yeah, it's an awesome product to use for your patients that are suffering salivary flow issues.
Okay, next question. Is nighttime lemon licorice tea effective?
I would imagine so. If you're going to be, you have to look at your patients. If they don't have good saliva, you want to have them rinse with water or something after drinking something a little acidic. I don't know what the pH of a lemon licorice tea may be.
Sure, that would be something to look into, I suppose. They don't put that on the label, though, do they? That would be a nice thing to label, actually. Except I don't know how they could do that because it depends on who's taking it, probably, to some extent. Somebody wants to know what's involved in inviting you to present at my next study club.
Well, all you have to do is call me because I am very excited to be speaking on all of these kind of topics at any time. You can reach me at crosslinkpresent@aol.com, crosslinkpresent@aol.com.
Okay, great. And we'll be sending a follow-up email with your contact information as well.
Great.
Just a comment here. Raisins were condemned as highly cariogenic specifically because they are so sticky and retentive. I guess that's...
Yeah, no, that's not true. They dissolve very quickly when they're in the mouth. The sugar dissolves very rapidly in people with saliva.
Okay. Are you familiar with the canary system?
I am familiar with the canary system. It's a pretty neat system. It's a little different with respect to checking decay. It is very effective underneath amalgams and other restorative material or prosthetic material, as I like to say. So it's, I think it's the only one that can breed decay underneath restoration.
Right, and again, just because we actually had the inventor of the canary system speak, Dr. Stephen Abrams, a couple of months ago. That's another archived recording we can share with people if they would like. The next question we have time for is, do we know why there is a higher prevalence of lactobacillus, or was it strep mutans in the elderly?
It's in the deeper decay and in root decay we find more lactobacillus.
Okay, so it's just a matter of time.
It's a matter of time and surface. It appears that they grow better on the surface of the roots than they do on the surface of the tube.
Terrific.
And elderly people have more root exposure. So.
Oh, that, of course, more gum recession, sure.
Mm-hmm.
Okay, well, we're a little bit past our promised 90-minute cutoff. I want to thank everybody for staying. I'm sure if you did, you enjoyed Shirley as much as I did. It's always a pleasure to hear from you, and I want to thank you again for such a lively and informative presentation. You truly never fail to please. And I want to again thank sincerely once more Springstone Patient Finance for their commitment to helping make dentistry affordable, which of course makes both patient and practice happy and healthy. And remember to watch your email for instructions on how to receive your 2 hours of CE credit. Again, we ask for your patience in receiving this email. If you don't get it by Monday, June 30th, do not hesitate to let me know. And finally, please be sure to mark your calendars for Wednesday, July 30th at 6 p.m. Central Time, when our special guest presenter will be Mr. Bill Rossi. Bill will deliver a both timely and practical way to gain treatment acceptance that he calls clinical calibration. Definitely not your ordinary case presentation. In the meantime, this is Danny Bobrow thanking you for your continued commitment to practice perfection. Goodbye, everybody.